I got a lot of requests to talk about craniocervical instability, so here's my take on why most chiropractors probably shouldn't be touching these patients. Craniocervical instability is a condition in which the structural integrity of the upper part of the neck, meaning your skull, your C1 vertebrae, or your C2 vertebrae, have lost the integrity of the ligaments of the spine. This can happen from severe injuries like a really severe whiplash or traumatic brain injury, where the force of the collision can actually cause tearing of those ligament structures. But the reason I want to talk about today is because one of the most prevalent reasons why people are coming in with craniocervical instability is actually because of a condition called Ehlers-Danlos syndrome. Ehlers-Danlos is a genetic condition where the body struggles to make functional connective tissue, and that connective tissue can include the ligaments of the joints of the spine, but it also affect things like the skin and even the layers of your arteries and other structures inside of the body. There's been increased awareness of when Ehlers-Danlos affects this upper cervical region because this can be associated with a wide range of symptoms ranging from autonomic dysfunction, chronic headaches, drop attacks, even pseudo-seizures and things of that nature. When most people think about chiropractic, they think about a high velocity thrust manipulation, kind of like you see over here and on your favorite TikTok and Instagram reels. Now, the purpose of these types of manipulations is to actually break up fixations or areas that aren't moving that well and to increase movement into that area. But if you have Ehlers-Danlos or other types of cervical instability, that area of the spine already moves too much. So if anything, you are only adding harm into a situation when you're trying to increase the movement into that joint. This might potentially be harmful for some patients with hypermobility because we're entering into something called the paraphysiological space. When we move a joint, there are different types of range of motion. When we use active movement, that means our bodies are actually moving of your own power, which is usually going to have less range of motion than passive movement. Passive movement is when someone takes your hip bone joint and actually moves it for you, which means you could usually squeak out a couple degrees more range of motion. When we're doing this type of manipulation, you're actually entering into something called the paraphysiological space, which means the body is brought to its end range of passive movement and then you thrust into it. If you have normal soft tissue integrity, then this is no big deal. But if you have something like connective tissue disorders and hypermobility, then you're likely pushing into a range that is beyond the ability for that connective tissue to actually maintain structural integrity. That means that that joint and the ligaments of that joint are more likely to be sprained and for it to cause injury. Another issue is that people with hypermobility are severely understudied. If you try to go to the literature, there are zero randomized trials on how to manage people with cervical instability, especially related to hypermobility syndromes. So that means we have to rely on expert guidelines and expert consensus to determine what we're supposed to do with these patients. So this is my favorite guideline that we see, and you can see one of my favorite authors, Julia Trelevin, was involved in this. The thing that's good about this paper is that it organized patients with hypermobility into high irritability, moderate irritability, and low irritability patients with cervical instability. And this is where you can see that even though I'm very pro anti-fragility, this is one of those situations where if you have a very unstable patient, that neck bracing is probably appropriate for the high irritability patient. But manual therapy is probably going to be a no-go for these high irritability patients because they're too sensitive to almost any type of manual type of work. But for the very unstable, high irritability patient, we might use eye movement exercises, relaxation and autonomic training, breathing exercises, pain neuroscience training. But the good news for the low and medium irritability patients is that the consensus guidelines do support the use of gentle manual techniques at C1 and C2 if the therapist is trained. Some of these techniques can include NUCA, Atlas orthogonal, activator, or a whole host of other interventions that chiropractors might be able to do that don't cross into that paraphysiological space. But even in that scenario, while many chiropractors have gentle techniques in their toolbox, they might not have much experience working with the hypermobile patient, which is really important because unless you're examining that patient and getting a good history and performing some of these tests to test some of their irritability, you might not know if they are mild, medium, or high irritability type of a patient. And if we're living by the principle of at first do no harm, then we have to do our due diligence of making sure that we thoroughly examine and get a good history on these patients so that we're not putting that patient in harm's way just from being a part of our practice.